Right. Is everyone here? Huh? Good evening to everyone. Guys, turn your cameras on. Let me see your faces. Huh? Okay, so yesterday, I got some interesting questions after the class. So one question was, do we always have to call the patients Amma or Tata? I mean, after the after this initial introduction part, I think yesterday. So here, guys, now it's like this, right? Depending on the age, depending on the age, you don't need to. Let's say the patient is coming in and he seems younger than you, and you're taking the history. He says, "I'm 18 years old." You can't call him Amma, Tata, no, right? He will be like, "Doctor, I'm not your father," right? Okay. So in that kind of a case, for me personally, I usually say, "Oh yeah," right? "Oh yeah, it's okay," right? You have to obviously don't use your tone always, right? ඔයාගේ අද ප්‍රශ්නේ මොකක්ද, right? ඇයි අද ආවේ? Things like that, right? Why did you come, right? Personally, I never have called a patient Obatuma or Obatumia, right? It's I don't know. It's for me, it's a personal thing. It feels a little bit weird sometimes. Okay, but it's personal preference, right? Whatever you all are comfortable with, right? Go ahead with that. As long as you get the history from the patient, that's it. Okay, you can call the patient whatever you want. Just use your tone and talk nicely, right? And then another thing yesterday, thank you for mentioning, we forgot to look at the images of multiple myeloma. It's there in your, take your skeletal note, guys. Let me share the screen, right? Right, look at this, guys. Yeah, right here, right? We forgot to take a look at these images now in multiple myeloma. In multiple myeloma, guys, we learned a basic introduction to the pathophysiology, right? It's actually very deep, right? Much deeper than what we discussed. But what is the basic pathology that is happening there? What is, just give me an idea of what is happening in multiple myeloma. Anyone? Don't look. I see you all reading yesterday's notes. Don't look at yesterday's notes. What's happening?
Gamma globulin levels.
Right. First thing, why is gamma globulin increased? What is the cause?
Hyperproliferation of the plasma cell.
Yeah, it is a plasma cell cancer, right? Cancer of the plasma cells. So there is hyperproliferation, therefore, yeah, gamma globulins are going to be high, right? So what will you see if we do imaging? What did we say we are going to see? We talked about, sorry,
lytic lesions.
Yeah, lytic lesions, right? Remember we talked about this osteoclastic activity and the osteoblastic inhibition, right? Therefore, we are going to see these lytic lesions, right? These are the lytic lesions, guys. Okay, right? So you can see lytic lesions here wherever, guys, wherever in your body, right, where hematopoiesis is happening, there is a chance of you finding the lesions. Okay, right? It can be any, most of the flat bones, for example, the bones in the skull. Look at this. Can you see this? Right? These are all lytic lesions. All lytic lesions. Look at the spine, right? You can see here as well. Here, what can you see? Here, where can you see lytic lesions? Where can you see? Tell me where. Where can you see?
Scapula.
Yeah, look at the scapula, right? Scapula, right? Look at these. These are all lytic lesions, guys. Okay. And here also maybe, I think it's not very clear, but yeah, possible. Possible lytic lesion there as well, right? And then this is again at the in the pelvic area itself, right? Okay, and the femur. Okay, so these are the lytic lesions in multiple myeloma. Okay. Usually, guys, most of the time, by the time the patient comes and by the time you're diagnosing multiple myeloma, most of the time you will find these lesions in at least 2 or more different locations. Most of the time, right? It won't be isolated to only the spine or only the scapula. Most of the time, by the time the patient comes, you will see these in a lot of areas. Right. Then guys, another point to mention. Yesterday, right, look at this. Let me write it here. Right. Yesterday, guys, we talked about this spinal cord stenosis and root canal stenosis, right? A few more things to add there. Go there a little, guys. Is this? Where did we write this? Yeah, here, right? Look at this. A few more points to add here. One thing, guys. Now, what did we say? When there is lumbar spinal stenosis, it is more likely to cause cord compression, right? Cord compression. Now, you all understand this, from this diagram itself. From this diagram itself, as this disc starts bulging out all around, there can be some cord compression. Apart from that, the root canal stenosis, we mainly said due to the osteophytosis, right? And the abnormalities in the adjacent bones, it can disturb this outgoing nerves, right? The outgoing nerve root rather, right? Now, here guys, so if there is cord compression, right? If there is cord compression, guys, what can we see here? What can we see here? One thing, we can get pain and paresthesia. What is this paresthesia? What is paresthesia, guys? What is paresthesia?
Weakness.
Weakness? Where? Paresthesia, not paraplegia, not paraparesis. Paresthesia means sensation, guys. Sensation, right? With regards to sensation. So abnormal sensation, this tingling sensation, numbness, these kind of things, right? This is paresthesia, right? Apart from that, yes, you're correct. We can also have paraparesis. Paraparesis, right? This is what partial loss of motor function. Motor function. The patient's voluntary control can be lost a little. If it is paraplegia, what is it? Complete loss of motor function. Okay, complete loss of motor function. Depending on the severity, these can be there. Apart from that, guys, one thing we didn't mention yesterday, right, is this neurogenic claudication. Write this down. Neurogenic claudication. This is important, right? This neurogenic, okay, look at this. What is claudication, guys? Now you all might have heard this word claudication. What is claudication? What is claudication? Huh? You all might have heard vascular claudication, right? You all might have heard, right? Claudication, guys, mainly the definition is pain in the thigh, calf, buttock region that is provoked, right? That is provoked by activity. Pain that is provoked by activity. This is what claudication is. Now, claudication, the common one, guys, the common one is vascular claudication. Basically, what is happening there? Due to some vascular problem, right? These are surgical topics. Due to some vascular problem, what is happening? The vessels are getting either going into spasm, getting contracted, whatever, or there is some sort of atheromatous lesions or whatever, right? Due to some causes, we're not going to talk about those now. What is happening? Blood supply is going to reduce. So the muscles are going to be ischemic and pain is going to start whenever the patient walks, right? Whenever the patient walks. Okay. When the patient is at rest, that reduced blood supply is still enough to supply those muscles. So there is no pain. But whenever the patient walks, as the demand for blood supply by those muscles increases, but the vessels cannot provide that supply for that demand, therefore pain starts. Okay, that is vascular. Here, guys, this is neurogenic claudication. What is this neurogenic claudication? Same thing, pain, right? Pain in the thigh, calf, buttock, same thing. And pain again on walking or standing, right? Write this down. Pain on walking or standing, depending on the severity, right? And relieved, the pain is relieved on rest. Basically, guys, relieved on rest. I want you all to mention here specifically on sitting down or leaning forward, right? Leaning forward. Pain on sitting down or pain on leaning forward, right? Okay. Now, when the patient is presenting with a pain like this, right? Pain like this, how can you differentiate that from vascular claudication? Just try to be logical and think. If there is a vessel problem, especially an arterial problem that is not allowing blood to come enough to the musculature there, or any part distal to that, what else can you look for that might help you to determine if it's vascular claudication or neurogenic claudication? Because the manifestation, the patient's complaint is similar. Doctor, I have pain when I stand, when I walk, right? And when I rest a little, it's gone. Okay. Now can you can you all guess something? Just imagine. Just okay, I'll give you all some hints. Okay. When blood is passing through some arteries, guys, right? Some arteries, right? Okay, I'm just giving you all the answer, right? Those when blood is passing through certain arteries, especially that are close to the skin, we can, you can usually touch and feel a little, what can you feel? What can you feel? You can feel pulses. You can feel pulses. Now, if the arterial blood supply is being less to that particular area, the distal areas, what do you think about pulses? Pulses can be absent, right? If it's a case of vascular, pulses can be absent. But if it's neurogenic, any problem with the pulses? Any problem with the pulses? No, no problem with the pulses. Okay, vascular, there can be absent pulses. Write these down now. Okay, now, okay, I have given you all one. Anything else just by looking at that patient's limb or hand or whatever, or leg? Anything else you can think about? Again, related to
color.
yes,
Pallor.
excellent. The color, right? Pallor. Look for pallor. Especially since we are talking about the leg, look for pallor in the foot, right? If there is pallor, that is likely that it is a arterial claudication or vascular claudication. If there is no pallor, if the patient's foot looks normally pink looking appearance, right? Then there is a chance it's neurogenic claudication, right? And same thing, pallor, if it is worse, what will you see? If the first thing is pallor, if it is worse vascular problem, what will you see?
Blue discoloration.
Sorry?
Blue discoloration.
Yeah, what is the word? Cyanosis.
Cyanosis.
Right? Cyanosis, right? If it is cyanosis, also another indication that there might be vascular problem, vascular claudication, right? Then, guys, look at this. Another feature. So those are the main three, right? Peripheral pulses. You want to look for peripheral pulses. You want to look for pallor. You want to look for cyanosis. Okay. Apart from that, using the stethoscope, you can listen to arterial bruits and all of these things. Fine, that's okay. Apart from all of that, guys, look at this rest. Why did I say particularly to write down for the neurogenic claudication, sitting down and leaning forward? Why did I say this? In vascular claudication, guys, right, it is relieved by rest no matter what the position is. Even if the patient is standing and he's walking, let's say he's walking, okay, he's walking, now he feels some pain, he just stands and stops for a while, the pain goes away, right? That is vascular claudication. Neurogenic claudication, guys, even if the patient is standing, why? If the patient is standing and if the bulging out of the disc is a little bit severe, what can happen? It can still be compressing on the nerve, right? So they have to sit down and they have to sometimes lean forward. Do you all understand what happens when you sit down and lean forward to the nerve? Look at this, guys. Especially since we are talking about this lower limb, right? Just try to get the picture. You all know our lumbar spine, it has a curvature, right? It's what we call the lordosis. There is a slight curvature in the normal spine. Normal spine. This is the normal spine. You all know this. You all have discussed this. I think Sasanga taught this to you all, right? So it's something like this, no, guys. So if I draw, this is lumbar. Your lumbar spinal cord is something like this. There is a slight curvature there, right? It's something like this. Now let's just take some of those here to the side. Okay, I'm going to draw these. These are my lumbar vertebra. Normal, this is normal person. 5 lumbar vertebra. Okay, 5 lumbar vertebra. And let me draw the intervertebral disc as well. This is the disc, right? This is the disc. Okay. Something like this, right? These are normal one. Now what will happen, guys, when there is, let's say, spinal canal stenosis, right? Spinal canal stenosis, what is happening all around, let's say L1, at this L1 level, there is going to be some bulging out of this. Now, posteriorly, what is going? Our spinal cord. Our spinal cord is going here, right? Like this, like this. Now look at this. When the patient is standing, right? This is how it is in the patient's normal position when he's standing. What happens, guys, when you sit down? Just, you all can just stand up now and try. When you all stand up, you all will feel that your curvature is a little bit more. When you all sit down, what happens? That curvature reduces a little, right? Your lumbar spinal curvature reduces a little. So what happens, guys, when you sit down? When you sit down, right, these vertebra, this curvature reduces. So it'll look something like this now, right? Much more straight, right? Still the curvature is there a little bit, but much more straight than before, right? Then what happens now? The same thing. What happens, guys? That bulging out portion now moves a little bit there, right? Moves a little bit inwards, right? So that stress on the spinal cord goes away a little bit, right? Okay, that is why pain is relieved. And sometimes this is further aided if the patient lean forward, right? If they lean forward, further this curvature reduces. Therefore, that bulging, that compression of the spinal cord reduces. Okay, so for a neurogenic claudication, just standing up and resting will not solve the problem. Vascular claudication, yes. Okay, vascular claudication, yes. Right? Okay, is that clear? Give me a thumbs up if you all understood that point. That is important, guys. It's good. This difference between neurogenic and vascular claudication is actually a big chapter in surgery, right? We all will learn that. Right. Okay, then what else did we talk about yesterday? Right. Right, another thing, guys. Okay, are you done, right? Write down. Okay, can someone, until everyone writes down, can someone tell me lumbar spondylosis? When you hear the word lumbar spondylosis, okay, I'm your I'm a friend, I'm a junior for you all coming in the first year, and I'm asking, Ayya, Akka, what is lumbar spondylosis? I heard this doctor saying, I don't understand what that is. What are you going to tell me? Anyone? That point and ask. What is lumbar spondylosis? What can you tell me about lumbar spondylosis? Anything? Yesterday we talked about? Don't remember.
When the stenosis is severe, there'll be fractures in the lamina, the pars intraarticularis.
Right.
So the bone won't. I mean, in the X-ray, you could see that.
Right. Okay. Will rheumatoid arthritis lead to lumbar spondylosis or something like osteoarthritis?
Osteoarthritis.
This is usually worsening, right? We said prolonged. If osteoarthritis is allowed to continue, especially, right? This is when you get these degenerative conditions, guys. All of them can be related to osteoarthritis, right? This usually starts off with osteoarthritis. So when you're looking for them, will you see features of osteoarthritis in those joints? Let's say a patient, you diagnose lumbar spondylosis. What will you see in them? What will you see in them? you can see, guys, true, you're correct. In the X-ray, we can see certain things. The fracture we can see, right? Good. We can see fracture at the pars interarticularis. Apart from that, guys, don't forget. I forgot to stress this yesterday. I knew, that's why I asked this today also.
Right.
You can, yes, always look. You can see any features. Any features are possible of osteoarthritis, right? Any of the imaging features can be seen, right? Okay. So just keep that in mind. Osteophyte formations, right? Subchondral bone sclerosis, all of those, right? Remember that. The fracture, right? It's not in everyone. Not everyone will have the fracture, right? If the fracture is there, it's good for you for the diagnosis, right? It's easier for you for the diagnosis, but it's not a must for the fracture to be there. Okay, right? Right. So you can look for all the signs of osteoarthritis, and then yes, you're correct. What about if we do MRI? Will we see anything in MRI in lumbar spondylosis?
Dehydrate.
Yes, disc dehydration, right? Disc dehydration, right? Okay. Then, guys, what I want to mention there is, right, all these degenerative conditions that are coming from osteoarthritis or lumbar spondylosis, right? We talked about root canal stenosis, all of these things. Look at this. So this is one of the starting points of it, guys. This is one of the starting points, right? Okay, we get this, the disc that is going to bulge out a little bit from all the sides, right? Just thinking about this. Can you all tell me, now you all know, okay, let me draw the nerve roots also exiting this way. Nerve roots are also exiting like that, right? Nerve roots are also exiting like that. Just by looking at this looking at this diagram, can you all tell me this? These degenerative conditions, especially going with osteoarthritis, right? Lumbar spinal stenosis, root canal stenosis, lumbar spondylosis, these things, usually will they present with the bilateral presentation or a unilateral presentation? What do you all think? Just look at this diagram and tell me.
Bilateral.
Lateral.
Excellent. These ones, guys, most of the time present bilaterally. Doesn't mean unilateral is impossible, right? Unilateral is possible, but most of the time, these degenerative conditions that we talked about yesterday, right? They present bilaterally, right? Rarely can be unilateral. Okay, they present bilaterally. Why this is important, I will tell you all today when we go to the anatomical ones, right? We will see most are unilateral. We'll talk about that next. Okay, just note it down there. All these degenerative ones that we talked about, right? They usually present bilaterally. Okay, right. With that, let's go to today's topic: anatomical issues. Right. The first one is, guys, slipped disc. Right. If you look at our classification, we called it slipped disc. What is this slipped disc? Look at this. Now, again, think of our lumbar curvature a little. Look at this, guys. This is our normal. I'm drawing a normal person's lumbar curvature. Look at this. Something like this. Okay. And then we have the disc here. Look. Okay. I'm going to ask you all a question. Look at this. I'm going to draw something like this here versus here. So this is A side, B side. In our normal spine, guys, these are lumbar, these are lumbar spine. In the normal lumbar spine, if you look at the curvature and if you consider all of these lumbar vertebral discs, right? Which side do you think? So A is posteriorly, right? Here is the spinal cord going, right? Which side do you think that of the vertebral disc is under a little more pressure, the A end or the B end? Just look at the diagram. A, right? That is understandable. You all can see, right? This is normal, right? Your A, basically the posterior aspect of your vertebra, right? You all can see this, right? Yeah, here is these are Model yesterday. So somewhere here is the disc. The disc is between these two bones. I have put only the bones in this. So the posterior disc is under a little more pressure compared to the anterior discs. Okay, everyone understands that, right? Okay. Now having understood that, guys, let's look at this normal structure. This is the normal one, right? This is the normal one. So we have the annulus fibrosus and the nucleus pulposus. Tell me, annulus fibrosus consists of what? Annulus fibrosus consists of what?
Fibrocartilage.
Fibrocartilaginous structure, right? This one, guys, you all can further write down. It has what we call, can you all see these concentric sheets? We say concentric sheets of collagen fibers. Okay, concentric sheets of collagen fibers, and the fibrocartilage is annulus fibrosus. It connects to both the vertebra above and the vertebra below. Okay, you'll understand that structure now. Right. Nucleus pulposus. What is the main constituent?
Water and
Water. Yeah, water and some loosely arranged collagen. Water is the main component. So this is nucleus pulposus, guys. It is a jelly-like substance, right? It is jelly-like. It is jelly-like. Okay. Water is the main one, plus some loosely arranged collagen. Okay. Now look at this. Now, okay, just in this diagram, okay, I'm drawing some. I will say somewhere from here to here is A. All of this is A. And this is our B portion. Right? B portion. A or B, right? From the same question I'm asking from the previous one. Which one is under a little bit more stress according to our normal lumbar curvature?
A.
A, right? This is what I want you all to understand here. Crucial to understand the mechanism. Look at this. Now we'll see what is happening, guys. Due to various conditions, right? It can be age related, right? Stress related, sudden heavy lifting, recreational sports related, occupational related, whatever, right? Whatever. Due to whatever condition, sometimes due to congenital defects as well. Sometimes due to congenital defects as well. Whatever reason, what can happen is, guys, due to the increased shear stress compared to the B region, this A region can develop some weaknesses. Look at this. Let's draw it like this. Let's draw the same thing, right? And then here we have the nerve, right? Something like that, right? And here you can draw the same thing. I just draw the same thing. We will draw inside the something like that. Yeah. So this is the one. And what we are going to see is, guys, now look at this. The inside, wait until I tell you how to draw. You're going to see a small defect here. Right? Look at this. What we can see is, guys, right? This outer layer of the annulus, it starts bulging out a little. It will be intact, but it will start bulging out a little. Look at this. So let me draw the annulus, something like that. Right. It will develop a weakness, guys. What do I mean by weakness? I will leave that weakness in a light blue. The rest will be dark blue. Now this area is weak, right? The light blue area is weak, right? From this light blue area, right? What happens? It will develop this weakness there and it will start bulging out like this. At the same time, guys, in the center, what is there? Our nucleus pulposus, right? Nucleus pulposus. Our nucleus pulposus will also start bulging along with that a little bit, right? Also start bulging a little bit, right? Like this, something like this. Just remember, right? You all can take another blue color or something and draw this border here, right? Just remember that that border is intact, right? That border is not yet broken, right? The outer layer of the annulus is intact, right? Let me stress on that a little, like this. Outer layer of annulus is intact, okay? Is intact, right? Now what is happening, guys? When it bulges out like this, what can happen? It can touch on this nerve root that is coming out. It can touch on this nerve root that is coming out, okay? Right? Now, If you all remember the previous one that we talked about, right, in lumbar spinal stenosis or root canal stenosis, right, there what did we see, guys? The bulge was where? Was it in one focal point like this, the bulge? Right? Did you all see the? No, we saw it where? It was going all around. There is a slight bulge, right? All around there can be a slight bulge. And that's why we said it is mostly bilateral. It is mostly bilateral. Now look at this. This is a unilateral. This is a focal lesion, guys. This is a focal on one side. On one side, right? Through this weakness, what is happening? It is bulging out. This is what we call, guys, a bulging disc. Huh? This is what we call a bulging disc. Bulging disc, or what is the professional word? PIVD. What is this? What is this? What does PIVD stand for? Prolapsed intervertebral disc. Okay, this is what we call a prolapsed intervertebral disc, right? Prolapsed intervertebral disc. Okay, right? I will tell you all the next one, right? We'll talk about, we'll see what happens to the outer annulus. In this one, remember, outer layer of the annulus is intact, right? Intact, it's just in contact with the nerve, right? Now look at this, guys. When this happens, how do you think the patient presents to you? Especially, let's say the patient hyperextends a little for something. They hyperextend a little. What happens to this bulge? Goes and this one presents, guys, with an acute type of pain, right? Suddenly the patient, he does some movement, right? Moves a little bit, pains, right? Okay, this is mostly, guys, mostly it presents with the acute type of pain, acute onset pain. Okay, acute onset back pain. Okay, and majority, guys, majority. Now here we here, okay, let me draw the sacrum. You all know, guys, when we come to the sacrum, suddenly there is a change in the curvature, right? You all know the lumbar spine comes like, the curvature comes like this, it's the lordosis, and then to the sacrum it goes to the other way, the curvature suddenly changes, right? So the most common place for this to happen is here, guys, between L5 and S1. That cartilage, that lumbar disc is the most common one to get this prolapse, okay, between L5 and S1, okay, because of the sudden change in the anatomical shape, right? Okay, that is normal, the shape is normal, right? But the shear stresses and forces and everything are different, so there can be more injury, they are more prone to injury rather, right? Now look at this, guys. How will this patient complain to you, right? First thing, acute onset pain, we already know that. Write down, guys. Another thing, pain exacerbated suddenly with sudden movements like coughing, sneezing, right? Or sometimes even Valsalva maneuvers, right? Coughing and sneezing, and sometimes with Valsalva maneuvers, right? So sudden jerky movements, right? This pain can suddenly come up, okay? Coughing, sneezing, or Valsalva. This is not specific, guys. This is not highly specific only for the bulging disc. Sometimes even non-specific muscle spasms, right? Even those can be exacerbated when you cough or sneeze, right? Okay. But for our sake, for this chapter that we are talking about, right, we can look for this pain exacerbated with sudden jerky movements like coughing or sneezing. Okay. The next thing, guys, the next thing, when you're taking the history, right, you can look for any occupational causes or any recreational causes. For example, if the patient is an elite athlete, right, an elite athlete, right, they're always doing some sporting event, right? Especially these, you all know, guys, triple jumpers. These triple jumpers, right, are known to get this bulging discs. Okay, triple jumpers, right? Apart from that, Shashank, I don't know if this is what you were talking about yesterday or if it is something else, right? But sports related, yes, possible. Then also another thing to consider, if the patient is obese, also suspect a bulging disc possible, because, guys, to your vertebral column, right? Your vertebral column transmits a lot of your body weight, right? Especially say an obese person, if they jump up a lot, if they're dancing or jumping up a lot, their spine is under so much of tension. Okay, so obesity also is another thing. Smoking, write down. Smoking, very important. Why? Smoking, guys, they have found out, right? Not just for the discs. Smoking in general has an effect on weakening the strength of cartilage. Okay, okay. We are not going to discuss the mechanisms of this. Some of it is still under research, but there is a direct. They have found out a causality between smoking and weakened cartilage. Okay, weakened cartilage. All right. And apart from this, yes, the patient can present with manifestations of sciatica. They will say there is a sudden shooting type of pain going through that limb. And the sciatica is what? Unilateral or bilateral? Sciatica here is unilateral. Okay, unilateral. Remember that. Let's look at some images, guys. Let's look at some imaging. Right. Okay. A second. Right. There we go. Let's look at this, guys. Can you all see this? Let me see your faces. Right. There we go. Look at this, guys. Let's have a look at this. Let's look at the T2 first. T2 is usually clearer. Okay, look at this. Okay, so let's go layer by layer. Okay, right. Can you all see the defects? Can you all see the problem? Where? Can someone tell me between which levels? Between which levels do you see any defects here? Anyone? Look close, look close. What is this?
Just
What
about
is this?
yes, that's the sacrum.
Yeah, that's the sacrum. So this is your last lumbar vertebra, right? Okay.
Between that.
Yeah, L5 and S1. And guys, look at here. Let's go a little bit. Okay. This one also seems to have a little bit of a bulge. This one also seems to have a little bit of a bulge. But look at this. Tell me, is this bulge compressing on the nerves? This is T2 weighted. Tell me, is this bulge compressing on the nerves?
No, that's just CSF, right?
Yes, in T2 weighted, what did we say? Liquids are bright, right? So this whitish appearance is CSF. But look at this bulge. This one is definitely compressing on the on that side of the chorda equina. Okay, that side of the chorda equina, whatever branches that are coming out. Okay, this one not so much. This one not so much. Okay, right? So that's a huge one. That's a huge bulge actually. This is a very serious one, right? Okay, right. Let's go back. Right. Then this guy is okay. Right. Right. Look at this, guys. So that is about this disc prolapse. That is the disc prolapse I want you all to learn. Right. Now, guys, you all can put a small line there. Right. Further, if this condition, this is disc prolapse. Up to here, what we discussed is disc prolapse. If this condition further worsens, right, there is something called, guys, disc herniation, right? This is a progression. First it's the prolapse, then we get herniation. What is this herniation, guys? Nothing special. Look at this. You all can later draw the same thing. I will draw this a little bit here, right? It's basically the same thing, a little bit of a difference here. What's the difference, right? Remember we said in the prolapse, the outer layer of the annulus was intact, right? Here what happens, guys, that outer layer of the annulus tears out and this nucleus pulposus starts coming out, right? The nucleus pulposus starts coming out. This is what we call a ruptured disc, right? Disc herniation presents with a ruptured disc, right? Disc herniation, right? So the nucleus pulposus starts coming out. We call these guys extrusion, right? Extrusion and sequestration, right? There are two words there. You all can write both. Extrusion and sequestration of the nucleus pulposus. Nucleus pulposus, right? Extrusion and sequestration of nucleus pulposus. Okay. This is what we called a herniated disc, right? Disc herniation. This one, guys, similar presentation to the bulging disc, right? But the back pain is a little more severe, right? When this extrusion and sequestration of the nucleus pulposus happens, there can be immune-mediated inflammation going on there. So some inflammation can be added there, right? So the pain will become a little bit more serious. But apart from that, everything else is usually the same thing, right? Unilateral presentation and all of that. Okay, right? So this is the disc herniation. Okay, disc herniation, right? Okay. Right. Yeah. You guys turn your cameras on. It's difficult to teach to black screens. At least I can see if you all have understood or not. Okay, done. Right. Similar presentation, just that the pain is a little bit more severe. Okay, and there can be associated inflammation, right? Because this jelly-like liquid is now going to start coming out a little bit. Okay, right, look at this, guys. Now what do I want you all to write down? Put a red note somewhere. Note, right? Note. We'll come to this. Yes.
Will the pain be like less dependent upon movement because now the pulposus is already out?
No. Don't think about like that. Don't say it will be. No, don't think that it will be less dependent on movement. No, the similar. It is very similar, guys. This one you can usually diagnose it only from imaging, right? Only from imaging the difference between the two. Okay, difference between the two. Even then, sometimes it's difficult, right? But from imaging you can diagnose. From the manifestations, it's really hard to tell the two apart. Okay, you all might have seen in your maybe in your junior years when you all were learning, you all probably didn't even learn this difference. Okay, the difference between the bulging disc and the herniated disc, right? Sometimes they are considered the same, right? The difference is minor. It's just that this outer layer of the annulus is intact. Whatever happens, right, doesn't matter, guys. Doesn't matter what source is compressing the nerve. If something touches, even something, okay, how can I put this in words? Let's say even a feather touching a nerve and a piece of, let's say, something like a metal touching the nerve, doesn't matter, pain is going to be the same. Pain is going to be the same. Okay, right? You all know the in nerve conduction studies, you all might have studied the threshold, no? Right? So however it is stimulated, doesn't matter. Once it reaches the threshold, it's going to fire and the pain is going to come. Okay, right? Okay, then put a note. We'll come back to this prolapsed intervertebral disc. Tell me this. Write the note. PIVD, prolapsed intervertebral disc, is unlikely. Unlikely if. Unlikely if. What? Now you all tell me. It is unlikely if what? A prolapsed intervertebral disc. What is one thing now clearly you should tell me just after what we learned about the presentation? A prolapse in, okay, I'm coming with pain. You're taking my history, right? Ask me about my pain. Just okay, no need to go through everything. Okay, you're okay. Let's say someone asked me about the pain. Okay, I said, doctor, both my legs are hurting.
Yeah,
Is
if it's unilateral or bilateral, I guess.
excellent. PIVD is unlikely if first thing, if it is a bilateral presentation. Bilateral presentation. Okay, if it is a bilateral thing, you can try and exclude PIVD, right? Then think about the degenerative causes. Okay, if it is bilateral, right? That's the first thing, right? Apart from that, guys, second one, unremitting continuous type of pain. Unremitting continuous type of pain. Continuous type of pain. Now, in this one, guys, in PIVD, in the bulging disc, will it continuously pain? Will it continuously pain? No, usually when the patient is in a sudden position, we said sudden jerky movement, especially if they are coughing, right? Things like that, right? And it's not continuous. Usually, guys, when the patient goes to the bed to rest, it's fine. It's fine. Okay. What if it's a continuous, especially you all can write, especially if it is a nocturnal one, you all can definitely remove PIVD from the diagnosis, right? Nocturnal pains, right? What should you think then? Unremitting continuous nocturnal pains. What should you think? What should you think first? There can be a lot of causes. What is one of the first things? Huh? Cancers.
Cancer.
Yes, think of cancers. Think of cancers. Huh? Think of cancers. Right. Then, guys, the next one, third one. Unlikely if the third one, diffuse tenderness over the spine. Over the spine. What is this tenderness, guys? When you touch, it pains. When you touch, it pains. If there is diffuse tenderness, guys, in the back area, right, where when you touch the back area, if the patient is complaining of pain, it is unlikely that it's a prolapsed intervertebral disc, because that one usually pains when the patient moves. When the patient suddenly moves, he feels the pain. When you touch, you cannot, because you cannot put your hand inside his vertebral column and push on the bulging disc a little bit, to elicit the pain, right? Okay, so diffuse tenderness over the spine, unlikely. It's unlikely that it is a bulging disc. Probably another cause, can be a muscle spasm or the some of the cold lesions, cold abscesses that we talked about yesterday, something like that. Can be some multiple other causes. Okay, right. The next one, guys, the last one rather, is more than one nerve root involvement. Nerve root involvement. Now, how to look at how many nerve roots are involved? Today we will see in the physical examination, guys. Today in the physical examination portion, we are mainly going to learn about the three main ones, L4, L5, and S1. How to look for these, right? Usually, guys, it will be one of these three, L4 or L5 or S1. If we see multiple nerves affected, how we see multiple nerves affected, we'll look at in the physical examination. Don't worry, I will teach you. Okay, if multiple nerve roots are affected, it is unlikely that it is a bulging disc. Why? Bulging disc only happens in one. It can usually happen in one side, in one disc. No. Okay, you'll understand. Let's say L5 and S1. The disc between L5 and S1. Let's say this is the left side. This is the right side. On the left side, there was a disc, a bulge. Unlikely that on the same level there will be another bulge on the right side. That is unlikely, guys. That is highly unlikely. Okay, then it will be a bilateral presentation. Okay, that will be very, very, very rare. Okay, right? Possible, but very rare. Usually, if everything is going in this direction, everything is always already being sucked up in this direction. There is no energy to push anything this way. Okay, everything will be sucked up here. Okay, right? So highly unlikely, right? So these are the things to look for, guys, right? When we are trying to make a diagnosis of the prolapsed intervertebral disc or the bulging disc, right? And the disc herniation, same thing, same things, just a little bit more severe pain. Okay, right? Especially due to the surrounding inflammation, right? Okay, right. So that is, guys, the disc prolapse, right? The next thing, the slipped disc, is what we discussed. Now we are going to talk about, guys, slipped vertebra. Slipped vertebra. right? This is nothing special, right? We already talked about, look at this guys, spondylolisthesis, right? Look at this spondylolisthesis. What is this spondylolisthesis, guys? First point I want you all to know, it can be congenital. Sometimes, guys, babies during their development, right, fetal development, there can be anatomical defects, and congenitally they can present with some form, some levels of, some degrees of spondylolisthesis, right? Congenital. That's not what we are going to talk about today. Today we are going to talk about the acquired form, acquired form of spondylolisthesis. Okay, right? When we are considering the acquired form, guys, we have to consider certain things. First thing, if the patient has a history of trauma, of traumatic fractures, right? History of traumatic fractures, or any surgical procedures, guys, surgical procedures, right? Sometimes during certain spinal surgeries, guys, right, there can be always mistakes, no, right? Sometimes there can be some damages to that area that is going to result in spondylolisthesis, right? Then the next thing, guys, what is another likely cause for this acquired one? An exacerbated spondylosis. That means what? Probably a spondylosis that already had one of those fracture lines. Okay, an exacerbated form of that. Okay, right? And then the third one is, guys, any exacerbation of metabolic disease, metabolic bone diseases, especially, guys, we are talking about osteoporosis, right? Osteoporosis, because those bones are more likely to develop fractures, right? Osteoporotic bones, right? Okay, so this is how usually we acquire this spondylolisthesis. Otherwise, it will be congenital. It can be traumatic, right? It can be an exacerbation of spondylosis, right? So now you all know how spondylosis happens. Spondylosis, what did we say? Is usually an exacerbation from osteoarthritis, right? So can you see, it's all like a connection, right? It's all like a connection, right? One can lead to the other one. Doesn't mean always it has to be like that, huh? Doesn't mean always one has to lead to the other one. No, but most commonly that's how it happens, right? And then the exacerbated metabolic diseases. Look at this, guys. What is happening here? Let's take a look at this. Now, y'all, yesterday let's draw this, guys. Y'all can draw this. Now, let's take 3 of the lumbar vertebra, right? Something like that, right? Something like this. Okay. Came out a little wrong. Yeah, there we go. Right? This is how it is usually, you know, guys. Okay. Let me draw the disc also. Right. Now, what is going to happen, guys? Fracture at the pars intra-articularis, right? Fracture at the pars intra-articularis. Let's say we have a fracture like this, something like this. Okay, something like this, right? Or better yet, something like this. Now that's easier. Draw it like that, so that both of the facet joints are going to be. So this is usually, if only the fracture line is there, that is spondylosis, huh? Spondylosis. But doesn't mean the fracture always needs to be there for you to diagnose spondylosis. Spondylosis is just severe form of osteoarthritis of the spine. Okay, right. Now what will happen? Now what will happen when this fracture is there like this, right? Look at this. What happens next, guys? Okay. This bone starts separating, right? Okay, something like this. When this happens, guys, what is happening? Every time we move, right? Every time we move, this vertebra will undergo, because nothing is now holding this vertebra in place. Because can you all see both the superior and the inferior facet joints have been dislocated from the bone due to the fracture, right? Okay, so this bone is now free to move. The only thing holding it in place is the cartilage, right? Is the disc. The disc is the only thing holding it in place right now, right? And there may be some attached ligaments, but these ligaments are usually loose, right? They can move a little bit. So, right, this one is now not held in place properly. What is going to happen with time and with further degeneration and all of these, guys? Look at this. This is going to start appearing something like this. Let me draw this somewhere here. This one will move so much forward, something like this, right? Like that, yeah. Right? It will still be connected to a little bit of the, like this, there you go. Right? It will start appearing something like this, guys. Right? Do you see that? Right? Okay. Right? So why do we call this slipped vertebra, guys? One vertebra, right, slips over another vertebra. Now here I have drawn a very large gap, right? Very large gap I have drawn. Usually what it looks like is something like this, guys. Okay, not that, maybe not that close. Something like this. Yeah. One vertebra, especially the vertebra below, right? The vertebra on top slips over the vertebra below. Okay. The vertebra on, this is why we call it a slipped vertebra. Slipped vertebra. Okay. Slipped vertebra. Right? Slipped vertebra. Right? Okay. This one, where do you think? Okay, I've written it in your note, no? Most commonly where, guys? Again, right? L5 slip over S1. That is the most common. The second most common is L4 over L5. Okay. L5 over S1 is the most common place, right? It's there in your note, right? Right. Accompanied by fracture and fragmentation. Fragmentation is what we see here, guys, right? The pieces being broken into and being separated, right? Fragmentation, right? Now, look at this, guys. Are you done writing? Right. Okay, guys, let's take a look at some of the imaging here. Look at this. Right. Okay, this is an X-ray, guys. Let's look at the lateral one. Right. Right. Look at this, guys. Can you all see here? This between the L5 and this one. Between the L5 and this one. Right? L5 and this one. There is a better one. Let me show you all this MRI. Right. Look at this one. Look at this one. What has happened? Where is the spinal cord? This is the sacrum, right? This is the last L5, right? This is a severe one, guys. This is probably a grade, yeah, this is a grade 4, right? This is a severe one, right? Usually they grade it, guys. We don't need to know the gradings here. Huh? There's grade 1, grade 2, grade 3, grade 4, like that. This is grade 5 as well, right? So this is what can happen. Now tell me this. Most cases, based on this diagram, based on your knowledge of the spinal cord, right? Spondylolisthesis, tell me true, is this statement true or false? Okay, let's say, okay, forget the severity, right? Forget the severity. I'm just saying spondylolisthesis is just spondylolisthesis. There is no grading or anything. Don't go to think about this grading. Huh? Mostly, guys, mostly these kind of severe ones. These kind of severe ones are very rare. Huh? We don't usually see these kind of severe ones. Okay, usually we see these kind of ones, right? Mild spondylolisthesis. These are the most common ones. Just think about the anatomy and tell me. This statement, is it true or false? Most cases of spondylolisthesis are asymptomatic. True or false? Most cases of spondylolisthesis are asymptomatic. What do you all think?
True.
Why?
Because the spinal cord is not reaching there, so mostly there are no cases. Like
Excellent. Look at this, guys. Very good, right? This is what I want from you all. Right? Logical thinking. No need to memorize these. Let me share the screen. Right. Look at this, guys. You all know the spinal cord, right, runs here at the back, right? Runs here at the back, right? This specific fracture that we drew, right? Now what can you see? The facet joints are still intact, right? The facet joints are still intact. Everything is holding this in place, right? Facet joints are still intact. Only that vertebral body part is moving forward, right? Only the vertebral body part is moving forward. So is anything touching on this spinal column, on the cauda equina portion especially? Is anything, does it seem to be touching on this? No. Why? The vertebral body part is moving forward. It's not moving backwards, right? It's moving forwards, right? So spondylolisthesis, guys, most commonly, patient doesn't even know, right? Patient doesn't even know, right? But the problem happens when does the problem happen? When do you think? Just think about, again, anatomy. Think about this, guys. What if the fracture line, now here we got the isolated body going out, right? Isolated body is going out, right? Now think about this, something like this, right? This is the, what if the fracture line was something like this, right? What if the fracture line is something like this? Now who is going out and who is staying? This portion will stay here. This red portion will stay there. But can you see that top, the top piece can be broken off. The top piece can be broken off, and that piece can start pressing on this. That piece can start pressing on what? The spinal cord, right? Spinal cord. Okay. Do you all understand this anatomy, right? Just tell me, I want to make sure. If you all understand this, no need to memorize these statements, guys. Which one is symptomatic most of the time, which one is asymptomatic? No need to memorize. Now, when you understand this, you should know spondylolisthesis, right? Most commonly because we get the first type of fracture that we drew, right? The vertebral body moving forward while the rest stays, right? Because facet joints, guys, they are usually strong enough, but sometimes, depending on the condition, if there is osteoporosis, severe osteoporosis or something like that, fracture can be a complete one there with the fragmented pieces touching on the nerve, right? Okay, then tell me this. Now, most commonly, most likely, where did we say? L5 over S1. L5 over S1 is the most common. By this time, what portion of the spinal cord is there? By that level, what portion is there?
Correct.
Cauda
Cauda equina, right? Conus medullaris stops where? L1, right? By this portion, it's cauda equina. If by this portion it's cauda equina, now tell me this statement, true or false? Huh? These are all your questions. Huh? True or false? Spondylolisthesis commonly presents with cauda equina syndrome, or they give you manifestations of cauda equina syndrome. Something like what? Loss of anal sphincter control, right? Something like that. Is it true or false? False or true? Huh?
true.
Commonly presents with. Now guys, what did we say? Commonly the involvement of the spinal cord, is it there or not? Most of the cases, no. We said the patient doesn't even know, right? So presenting with cauda equina syndrome is rare for spondylolisthesis. Okay. So if there is, what are the manifestations of cauda? Okay, right, let's write this down. What are the manifestations of cauda equina syndrome, guys? Yesterday we talked about, recall, right? We mainly mentioned 3. What are they?
Loss of Perera.
Sorry, what? Loss of
Bladder and bowel.
bladder and bowel control. Good. What else?
Flaccid paralysis of legs.
Right. Good. What else? Saddle area numbness. Saddle area numbness. Okay, I can't believe I just did that on camera. Right? Okay. So that you all don't forget these things. Look at this. Don't forget those. Don't forget those. Right? So if the patient is presenting with cauda equina syndrome, what can you do? It is unlikely it is spondylolisthesis. Right? Possible, depending on how the fracture was, but unlikely, not very common. Okay. Right? So when you all are diagnosing this guy, these are the points for you all to help and narrow down on a diagnosis. Okay. Right? Okay. Guys, show me your, give me a thumbs up. Did you all understand this anatomy? Right? I want to make sure. Okay. Right. Okay. I see 2 thumbs. Okay. 3, 4. Okay. Good. Right. Okay. Okay. If you all don't understand, drop me a message after the class. Apart from this, guys, now tell me this. There is a fracture here and there is a dislocation here. When there is a fracture, when there is a complete fracture, will there be any pain? Will there be any tenderness in the area? Right? No? Have any of you all had a fracture before? Anywhere? Yes, it pains, right? There is pain, right? There is local tenderness, right? Write these down. Tenderness is present. When you're palpating it, the patient will say, okay, it pains, right? Why? Because there is a complete fracture here. There's a complete fracture here, right? And possibly with fragmentation, right? And then manifestations of cauda equina is rare, right? I hope you all wrote that down. The next thing is, guys, remember, pain, right? Pain is a little bit reduced on supine position. Pain reduced on supine position, right? Okay, this one, don't go to think too logically that the on supination, what will happen? Don't think that the bone will go and knock back up on the spinal cord. Don't think like that. Okay, don't think like that. It's just that the local pain will be a little bit less because why? The stress on the entire spinal column is reduced, right? When you are sleeping, when you all are resting on a supine, when on a bed or something, the stress on your spinal column is less, right? Because of that, the pain is going to be a little bit less, right? Pain is reduced on supine position, right? Difficulty standing and walking, all of these will be there. Okay, and depending on how much, right, the root nerves are affected, there can be paraparesis, weakness, these kind of things can be there. But just remember, presenting with cauda equina syndrome manifestations is uncommon. Okay, uncommon. Right? Okay, guys. So we are done with the basic stuff. Okay. Now we have to look at our neurological exam for this back pain, right? Neurological exam, right? Okay. Let's take another page, guys. Okay. neurological exam, right? Neurological, actually, you can do it here. No, let's make it easier. Let's take another page. Look at this. Put the topic neurological exam, right? For back pain. This specifically we are doing for back pain. Neurological exam for back pain, right? Okay. Now, this is not general examination, guys. Okay, general examination, I will show you all in the video. We just have to look for any kyphosis, any scoliosis, any lesions like that, things like that, right? We are not talking about the general exam. We are specifically, I want to teach you all the neurologic exam. General exam, nothing much. I will teach you all in the video itself, right? There is a video we got from YouTube, right? We couldn't get a hold of our model patient this time, guys. Right? Anyways, right? Look at this neurological exam. First thing I want you all to understand, what is radiculopathy, guys? What is radiculopathy? Nerve-induced pain, right? Nerve-induced pain. Some sort of pain in some part of the body due to a nerve problem, right? That is radiculopathy. Now, this back pain giving rise to radiculopathy most commonly happens from the from the levels of L4, L5, and S1, right? These are the three most common levels. So our neurological exam, we are going to focus on these three. If a patient comes with back pain, we don't need to do entire body's neurological exam, right? Unnecessary. You're going to waste a lot of time. Okay. L4, L5, S1 is more than enough. Okay. Look at this. First thing, motor, right? We are going to check for three things: motor, sensory, and the reflexes, right? Motor, sensory, and reflexes. We are going to check these three vertebral level, the nervous supply, right? Let's see. For L4, guys, for L4, right? The motor supply, right? We are mainly testing what? We are going to test knee extension ability. Knee extension ability. For you to extend your knee, you can see leg. For you to extend your knee, what muscle do you need? What muscle do you need?
Quadriceps.
Quadriceps, right? So what are we testing here? We are testing our quadriceps. We are testing our quadriceps femoris. Okay, right? What nerve supplies the quadriceps? Femoral nerve. Good, right? That is what we are actually testing here. We are testing the femoral, right? Basically the femoral, right? That is for L4. L5, guys, what are we going to look for L5, right? L5, guys, we are looking for dorsiflexion of the foot and the big toe, right? Look at this, write this down. Dorsiflexion of foot and the big toe, right? Right? Dorsiflexion of the foot and the big toe. Dorsiflexion, we'll see in the video. I will show you all. Right? S1, what are we going to test? S1, what are we going to test? Plantar flexion, right? Plantar flexion of the foot, right? Plantar flexion of the foot. Now, when we are looking for this, what do we tell the patient to do? Do we just ask him to lay supine and for the to extend his knee? Do we tell him to just extend his knee, or just dorsiflex his foot, or just plantar flex the foot? These neurological exams, when we are doing, guys, we prefer to take a active approach, right? What we do is we give some pressure against that movement, right? And we tell the patient, okay, now you extend your knee, right? And then you're going to put pressure on his leg. With your pressure against your pressure, he has to extend the knee, right? And what do we do? What's the principle there? We do this for both legs. We do for both legs. Compare if you feel any weakness on one of the legs. Okay, don't worry, when we watch the video, it will be much more clearer for you. Okay, we'll see how to do that. So that is the motor one, right? Apart from this, guys, let's say we do these three examinations, right? We will see how to do them. I will show you all. We do these three examinations. You notice, right, that there might be some sort of a problem with the foot one. Let's say the knee extension, no problem. Something you're not very sure, but there is something weird about the foot. So that means some problem probably in L5 or S1. How can we further confirm this? we can do another test, guys, a gait analysis. Look at this, for specifically for L5 and S1, L5 and S1, L5 and S1, gait analysis. These to further confirm, right? What are we going to do here? L5, guys, we ask the patient to walk on his heels, walk on his heel, walk on his or her, walk on the heels, walk on the heels. Okay, S1, what do we say? Walk on the toes, walk on toes, right? Walk on toes. Usually, guys, we give the patient a little bit of a room in front of us, right? And we tell, okay, walk 5 steps on your heels, right? And then to confirm, we say, okay, turn around, again, walk another 5 steps in this direction, right? On the heels, on the heels. And then for S1, on the toes, same thing, 5, 5, 5, 5, okay? 5 steps. What is walking on heels, guys? I want you all to, walking on heels is basically raising the toes, right? And doing that, no, walking like that, walking like that, right? When they're walking on the heels, guys, what do we want to look for? Look at both feet, right? If both feet are at the same level, raised up at the same level, no problem. I know this looks weird, right? These are 2 feet. If both heels are raised at the same level, no problem. If one heel is dropping a little bit lower, he's still trying to walk on the heel, right? But it's a little bit lower compared to the other, there is a possible weakness there. There is a possible weakness there. Same with walking on the toes. What is walking on the toes? Like this, no? Right? Walking on the toe, right? If one is a little bit lower than the other, somewhere like that, right? That means there is an issue. That means there is an issue. Okay? That's to confirm your from your dorsiflexion and plantar flexion. If you couldn't analyze it properly, then you can use the gait to confirm. Okay, gait to confirm. Right? Don't worry, we will see these in the video. Right. Then next one. So that is about the motor guys for L4, L5, and S1. Right. Next we'll come to the sensory. Now this is a lot of students are scared of this. Right. Look at this. Sensory dermatomes. Dermatomes. I think I have put a picture for you. Right. Memorize these dermatomes. Never ever do that. It's difficult. It's difficult, right? If you all can, I know there are some students who can, by all means. Cheers to you, right? For the others, I will teach a little bit of an easy method to do this. Look at this, guys. These are the actual dermatomes. This is the actual lower limb dermatomes. It's a little bit difficult, guys, to know these, to memorize these. Okay, right? Look at this. Look at this. Sensory. How are we going to do this? First thing I want you all to know, we are going to use a monofilament. You all know the monofilament, know that tiny, tiny piece of plastic or metal sometimes, right? It bends nicely, right? Make sure you don't stab the patient, but you can just place it on him. What do we tell them, guys? Usually first, while the patient's eyes are open, we keep the monofilament on the respective parts of his leg and we say, okay, this is the sensation you should feel. If you feel it, you tell me that you feel it or you don't feel it, right? That's what we tell them. And then while doing the examination, what should we make sure? Patient's eyes should be closed, right? Patient's eyes should be closed. You tell them to close the eyes and tell if they can feel it or not, right? Right. How do we do this in an easier way, right? Look at this, guys. Let's draw 2 legs. Okay, let's draw 2 legs. First we'll draw, after that I will show you on my leg. Look at this, draw. This is the anterior aspect. Say something like that. This is the big toe, right? Like this. It's a little bit difficult to draw feet, guys. Just draw. These are the nails. These are the anterior aspect. Right, something like that. This is the knee here, right? Right. Something like this, and then draw the posterior leg as well, right? We can draw a part of the gluteus, the buttocks, and then coming down from there, right? Calf muscle. Right? The foot is the little bit of a hard part, guys. Cannot help foot. We have to know the dermatomes a little bit. But the legs, there is an easy way, right? We'll see. Right? This here is the calf muscle. Huh? You can join the calf, something like that. Okay. I think it should come a little bit lower, but it's okay. Just draw a calf muscle there. Something like that. Right? And then draw these dermatomes also, guys. I will tell you all how to remember it. Right? Look at this. Right? This is a simplified dermatomes. Huh? These are simplified dermatomes for you all. Right? S1. Huh? Look at this, guys. So look at this L4 and L5. Huh? The separation where it's coming to it's basically splitting your splitting your big toe in half. Huh? Okay, splitting your big toe in half. So tell me this: the space between the big toe and the second toe. The space between the big toe and the second toe is supplied by what dermatome? Belongs to what dermatome?
L5.
L5. L5. Okay. Right? You all can see that, right? The space between the big toe. When I say space between the big toe, I'm talking about here. This is supplied by L5. Okay. Yeah. Back one also will draw, guys. Here is two. This one, right? And L4. Yeah. The foot is the little bit of a problem, but it's okay. What to do? Right? right? It's okay. We are not going to test the foot a lot today. Leg is the one we are going to focus on. Right? Okay. Done. Now, how to remember this? How to remember this, guys? This is generally easier than the other one. No? Does everyone agree with that? Does it look easier at least? It looks a little bit easier, no? Right? Look at this. Are you done drawing? Right. Look at this, guys. Right. Look at me. Y'all can now stand up and try this. Look at this. Y'all can see me, right? Okay. First thing, take your hands, right? Take your hands. First find your anterior superior iliac crest. You all know the anterior superior iliac crest, no? You all can stand and try. Sitting down, you can't do this. Anterior superior iliac crest, right? Take your hands, guys, and keep your thumb level at the anterior superior iliac crest, right? And your hand should be pointing towards your groin. This entire region is L1, right? From the anterior superior iliac crest all the way to your groin, right? All the way to your groin region. This is L1. Okay, L1. Then, right, L2, middle L3, and L4 above the knee. I'm going above my knee. L2, right? L2 this side. L3 a little bit of the middle and a little bit lower. L4 a little bit more lower, just above the knee, but the medial side, right? L2, L3, L4. That's how we go, right? L2, L3, L4. Y'all know that dance, no? There is a dance like that also. We used to do that, right? L2, L3, L4, right? Then another part of the L4 comes here, right? Another part of the L4 comes to the medial calf, your medial calf, right? L4. So it goes L2, L3, L4, again L4, right? L4 again. And L5 on the lateral side. Okay, L4, L5. Okay, clear? L4, L5, right? And then on this dorsum of the foot, you have to remember, guys, you have to remember the space between. Just remember that line going, splitting your big toe in half. If you remember that line, that's enough, right? Everything onto the medial of that is that continuation of your L4, right? Then on the other side is L5, a small piece on this lateral side, a small piece, right? A small portion on this lateral side is S1, right? S1, right? That is the front of your leg. Is that easy? Is that easy? Is that easier than the other one, right? I hope it's easier. Then back, guys. When you look at the back, right? First, right? Your hamstring, right? Your hamstring, the entire back for all intensive purposes. It's not accurate. It's not 100% accurate, but we consider your hamstring S2, right? Consider it S2, right? Then from the foot up to the back of your knee, from the foot up to the back of your knee, right? This part. Here, majority is S1. The L4 and L5 are again in the medial and the lateral. L4 and L5 again in the medial and the lateral, same as the front. Just a little bit pieces are coming, but majority is S1. Majority is S1. Okay, middle, through the middle of this part, S1. Okay. Then the back of the foot, guys, it's okay even if you leave it out today, right? Back of the foot, again, that corner part is the S1 portion, right? And then we have L4 and L5, right? Back of the foot, it's okay. Today, I want you all to focus on the legs. Try to remember the legs, right? So we have L1, L2, L3, L4. Then again L4. You can cross your hands again, L4. And then L5 on the lateral side and coming down. Okay. Is that easier? Try to remember that for your examinations. Okay. For your MBBS, that's more than fine, guys. That's more than fine. No need to remember, no need to try and memorize that. Other one, if you all can, it's by all means, go ahead. Okay. Right. Second, right. Now what are we going to do? We only need today L4, L5 and S1. L4, L5 and S1. Look at this. How are we going to look at it? How are we going to test this? Right. Let's write this down. For L4, guys. For L4. Right? Okay, I can't see your faces. All right. There you go. Right. Right. Okay. For L4, one second, that's right. L4, you can use the monofilament, right? You can use the monofilament. We say anterolateral thigh, right? Anterolateral thigh. Sorry, anteromedial, guys. Give me a second. Anteromedial thigh. Medial thigh or the calf, right? Anteromedial thigh or the calf. Okay. Okay. Anteromedial thigh or calf. Calf muscle. Your calf muscle. Gastrocnemius. Okay. Okay. Right. You can do the anterolateral thigh also, guys. Why we say anterolateral thigh also possible? Look at this. Here also is L4. Here also is L4, right? Coming here is also L4. Going to this side of the calf is also L4. Okay, from the actual one, if you look, even the anterolateral thigh you can do, right? Both you can do. Okay, just remember whatever is easier for you. Okay, right? Right, so anteromedial thigh, or you can write anterolateral thigh also possible, but just remember the levels, because that thing comes something like this, guys. If you look at that leg, right, if you look at that thigh, it comes like this, something like this. So somewhere here, if you are doing the anterolateral, you have to make sure it is somewhere here and not these two. Okay, that's why it's a little bit difficult, right? So any way that is easier for you, just make sure you get the test back. Now in the video we are going to look at today, right? They talk about the anterolateral, right? That is a video from Harvard University. You see, they are talking about the anterolateral. Same thing. Whatever is easier for you. L5 is constant, guys. That one, the space between, we talked about space between first and second toe. First and second toe, right? Space between the first and the second toe, right? Okay, that means the big toe and the second toe. Then for the S1, where do we do? Lateral aspect of the foot. Lateral aspect of foot, right? Lateral aspect of foot. So here, this portion, right? And even in the back, that portion, same portion. Our tiny finger, guys. Our tiny finger is by S1. Tiny finger is by S1. So lateral aspect of the foot. Lateral aspect of the foot. Right? Okay. This is where we usually use the monofilament. Right? Clear? Now, what is the important thing to note here when you are doing monofilament test? Always do both sides, right? Always do both sides to compare, right? Always do both sides to compare, right? Then, guys, the last one is the reflexes, right? Reflexes. Reflexes, what are we going to look for, guys? Again, L4, L5, S1. L4 you all already know, right? If it's the quadriceps, what are we looking for? What are we looking for? L4. Knee extension. What are we looking for? What's the test? Yeah, the patella tendon reflex. Patella tendon reflex. Right? Patella tendon reflex. The knee jerk, basically, our knee jerk. Right? L5, guys, what are we looking for here? Medial hamstring. Medial hamstring reflex. Your hamstring is made up of how many muscles, guys? What is your hamstring? Hamstring is your muscles here, right? Hamstring is made up of how many muscles?
3.
3 muscles. What are the 3 muscles?
Semitendinosus
Muscle.
and
Okay. Semitendinosus, semimembranous, and biceps femoris. Biceps femoris. These are the 3. These are your 3 hamstring muscles, right? If you all remember the structure, guys, let's just, you all can put it as a side note. Better to understand these things than memorizing. No, look at this. If you look at the leg, right, it's something like back of your leg. This is the back of your leg. This the, let's say, buttock somewhere here, right? We get these 3 muscles like this. There, coming there, there, and the other one coming this way, right? Is the biceps. Look at this. This one, guys. This one. This is the biceps femoris. Biceps femoris. Right? Okay. Here, these 2 are going usually together. They go together, right? Semimembranous, and semitendinosus. The inner one is the semitendinosus. Membranosus. Okay. Look at this. These 2 guys, the ligaments, right? The ligaments of these 2, they join, they are very close together. They are very close together, right? If you take your leg, put your hand here, right? Just behind your knee, put your hand. You can feel on the medial aspect 2 ligaments, right? 2 ligaments, 2 very hard structures when you especially tighten your leg, right? That is these 2 tendons. Right, on the lateral side, you can feel one single one. That is your biceps femoris, right? One single tendon here, right? Here, okay? That is your biceps femoris. Now, what are we going to do, guys? We want to elicit what we call these 2 together. We call this the medial hamstring. Medial hamstring, right? Tendons. This one, biceps femoris, what we call the lateral hamstring tendon. Lateral hamstring, right? For L5, guys, we want to test medial hamstring, right? For L5, we want to look at medial hamstring reflex. Okay, medial hamstring. So we will see, we keep the patient, we tell them to relax, right? Slightly leg bent, and we keep our fingers over the medial hamstring tendons, and then you tap. You tap to elicit the reflex. Okay, right? Okay. And then for S1, guys, S1. Now just looking at this posterior foot that we drew, what do you think for the reflexes? S1. S1. What are we going to try and elicit?
Ankle.
Yeah, our Achilles tendon, right? Basically the ankle jerk, right? Achilles reflex, Achilles tendon reflex, right? These are the 3 reflexes we want to look for L4, L5, and S1. Okay, L4, L5, and S1. Right? Let's watch the video, guys. Look at this video. Right, guys? I will mute the video because I took it from YouTube, and whenever we upload it to YouTube, otherwise it gets copyright. You get the copyright claim, right? So I will mute it and I will explain to you all what is going on. Okay. Look at this. Right. Right. Can y'all see this, guys? Y'all can see this, right? Oh, good, right. Look at this. So first of all, we are going to do a small general examination before we go. But generally, if the patient is presenting with back pain, what can we do? Right? Right? Give me a second, guys. Can't see it. Right. Okay, look at this, guys. So firstly, we are going to start off with the inspection. Okay, first just look at the contour of the spine. We are going to look for any kyphosis or any scoliosis, things like that. Okay. Okay. Here, guys, they ask the patient to bend over to look for the scoliosis, right? Because when you bend over, guys, even if the scoliosis is a very mild scoliosis, it becomes a little bit more exaggerated, a little bit more clear, right? Okay. Yeah, this is what we're going to look at it. One side of the spine is raised compared to the other. Okay, scoliosis. That is it for the inspection, guys. For the palpation is what we are going to just assess for tenderness, right? This is what we're going to do next. First of all, along the spine, guys, just using your hand, right, lightly palpate along the spine just to see if the patient is showing any signs of tenderness. If while you're palpating the spine, if the patient suddenly tells, okay, it pains a lot, what should you think of? What should you think of? One of the things, what should you think of? Guys, can you?
Spondylolisthesis.
Yes, spondylolisthesis. There might be a fracture. Okay, okay, that's one thing you should think of, right? You just palpate and come down, guys. Right? So after doing the spine, guys, that is just for the spine, you just use your forefingers and you tap downwards. After that, you use your thumb and the other, you can use the first or second fingers together, and you look at either side of the spine, right? Either side of the spine. So this is good for things like muscle spasms or something like a cold abscess, right? If the patient feels tenderness on either side of the paraspinal tenderness, this is what we are looking for, okay? Right. So we are trying to differentiate the spinal cause of pain versus paraspinal. Then, guys, there is the next thing called the tripod test or the tripod sign, right? What we do is, right, especially if the patient is complaining of something like a leg pain, right? What we can do is we can take the affected leg. We ask the patient to sit on the bed. We take the affected leg, and while the patient is seated, we raise the leg a little, right? We raise the leg a little. What is going to happen, guys? If there is pain, the patient automatically moves back, right? He moves backwards because of the pain and places both his hands on the bed to get support because of the pain, right? So basically it's like a tripod. You all know tripod has like 3 stands, no, right? So that's what we are trying to elicit, right? So yeah, especially if there is something like radicular pain, right? There you go. Did you see? He went onto his hands went onto the other side, extended arms, right? So that's a positive tripod sign. Next thing, guys, we are going to do the straight leg raise test, right? Right? So we elevate the affected leg first, guys, right? Whatever the leg that the patient is complaining there is pain, we first elevate that one and check, right? And what we do is, guys, make sure the knee is extended. Make sure the knee is fully extended, and we raise it to about 50 to 60 degrees, not more than that, because more than that, guys, sometimes even a normal person will feel some muscle stretch and some muscle pain, right? So until about 50 to 60 degrees, usually a normal person shouldn't feel any pain, right? Always look at his face while you're raising his leg, right? Sometimes the pain might not be too severe, but his face might show the pain, right? So even he doesn't tell you, he might still feel some pain, right? And then if the patient is feeling some
Prashant.
pain, guys, yes.
Prashan, can you move the black box?
There's a black box covering the video. We can't see.
Okay, give me a second, guys. Is it okay now?
No, I think that might be an overlay from Zoom or something on top of the video.
Okay, give me a
At the bottom
second.
of the screen.
Let me Wait, was it there from the beginning? Was it there from the beginning of
Yeah,
the
but it
video?
only covered like a small part.
Okay. Let me try this. Now, okay? Still
No.
no? Still no? What about now? Okay. Okay, wait. Okay, Shashank is drawing. The thing is, I cannot see it, guys. That's the problem. I cannot see such a.
I've sent a screenshot. You can check it if you.
Okay. Wait, let me try something. Let me try this.
Nope, still there.
Give me a second, guys. Okay, what about now? Now?
Okay. I don't know.
It's
Yeah?
gone now.
Yep.
Yeah, okay.
Good.
Right. I have no idea. There is some. Right. Okay, shall I play it from the beginning again? Are you all okay to go along? Okay, let's watch it from the beginning. Okay. First, the inspection part. Huh? Now, no problem, right? All good? Thumbs up.
Yep. Thank you.
Right. Look for any kyphosis or scoliosis. Huh? Right. Ask them to bend over to try to elicit the scoliosis better. It appears better. Right. Right. So here palpation, right? Just push or tap, nothing special there along the spine first, and then paraspinal, right? Right. Then the tripod sign, guys. Okay. Right. See the arms extended, and goes to the, he moves backwards. Right. Right. Straight leg raise test, guys. Right. Now, if the patient shows any pain here, guys, during the straight leg raise test, right? Either the patient tells you or you can see it from his face, right? Either of the two doesn't matter, right? What we can do is to further exaggerate that and confirm, right? Confirm that there is a proper pain. What we can do, we drop the leg down again about another 10 to 15 degrees and we dorsiflex the foot, right? We dorsiflex the foot. That will exaggerate, especially if the patient has a mild pain, it will exaggerate the pain a little and then you can confirm your diagnosis, right? You drop the leg a little and then dorsiflex it, okay? Right? So that will confirm the positive straight leg. Now we are coming to the neurological, guys. First, the motor, right? Again, L4, L5, and S1, right? This is what we discussed today, right? Right. L4, what are we going to test, guys? What are we testing for motor function of L4? Tell me. What are we testing? What are we looking at?
Knee extension.
Yes,
and
basically
dorsiflex.
quadriceps function, right? Quadriceps function, right? So what we are going to do is, guys, we are going to hold, right? We are going to ask the patient to bend the knee a little. We are going to hold. We are going to support a little. Now look at this doctor's hand. This doctor's left hand is using to support the knee. The right hand, guys, what he's actually doing is he's pushing down from his right hand. He's giving some tension to the patient. Okay. Okay. At the ankle, he's pushing that leg down. Now, what we ask the patient to do is, against that pressure, we are asking the patient to kick his leg, right? Okay. Thereby tensing up the quadriceps, right? Do in both legs, do it in both legs. Support slightly at the knee, push down at the ankle and ask the patient to kick up. So to kick up, now he has to overcome your hands force because you're pushing down at the ankle. For him to kick it up, he has to use some force. He has to use his quadriceps, right? So you do both legs and compare. Okay. L5, what are we going to look at for L5? L5, what are we looking at?
Dorsiflexion of the
Yeah, dorsiflexion of the feet and especially the big toe. What we can do here is, guys, we provide some pressure, right, to the big toe using our first index finger is enough, right? And we pull it towards us and we ask the patient to dorsiflex it towards himself, right? That's what we do, right? You pull it towards yourself, you pull the toes towards yourself, huh? And ask the patient to dorsiflex, right? Always compare both sides, huh? Always do both sides, okay? S1, what are we doing? Plantar flexion, huh? Plantar flexion. So what are we doing? Again, we are producing some resistance and asking the patient against our hands to plantar flex, okay? Right? We tell him to push down as hard as possible. Compare both sides, right? Now, if there is an L5 or S1, right, abnormality that we are not sure about, we can use the gait analysis, right? This is what we are going to do. So we are going to tell the patient to walk about 5 steps, firstly on his heels and then on his toes, right, for L5 and S1 respectively. Make sure you look at both legs. Look at both legs. Can you see the difference here? Look at this. The top one is the normal, bottom is L5 weakness. And he's trying to walk on his heels, but can you see the bottom one? There's a difference. There's a slight foot drop there. The foot is dropped lower, right? Then the toes for S1, same thing, same thing. You tell him to walk, you can see it slightly drop, okay? Right? Then we come to the sensory guys, right? L4, L5 and S1, right? L4, what did we say, right? Anterolateral calf or the anterolateral thigh or the anteromedial thigh can be, right? Both can be there, or the calf, right? Here he's doing the anterolateral guys, using the monofilament, he's doing the anterolateral. So he is going with the exact thing, right? So if you all can do that, by all means, go ahead and do that. It's better, right? Look for always discrepancy. You can ask them, always the patient should respond to you, right? You should communicate with the patient, tell me if you feel it or not, right? Okay. L5 guys, we test the space between the big toe and the second one, the space between the big toe and the second one. That's right. Again, always do both sides. And then S1, lateral aspect of the foot, okay, right? Then the reflexes guys, the reflex, right? Again, L4, L5 and S1. For L4, what did we say? Patella tendon, right? You all already know how to do the patella tendon. No, that one you all must have done it before also, right? Sometimes you can tell the patient to sit on the bed, or you can do this if it's easier for you all. L5 guys, medial hamstring, right? You have to place your fingers, you have to find the medial hamstring tendons first, then place your fingers over there, place about 2 or 3 fingers over that, and then hit using the tendon hammer, right? Right? Okay. This one guys, the L5 one is a little bit difficult to elicit. If you have tried it, it's not easy. It's not easy. The main thing is guys, positioning of the patient. Most of the time, most of the students they find it difficult because they don't position the patient properly. You have to make sure that their posture, their hamstring is not at all under any sort of tension. If it is, it won't elicit the sign. It should be completely relaxed, right? So when you're positioning the patient, right? Then S1 guys, S1 again, you can do it this way, or some students I know, they ask the patient to sort of kneel on the bed with their foot falling down, right? Whatever is easier for you all, to stress the Achilles tendon, right? This way, actually, I do not prefer. This one is a little bit difficult, right? But sometimes guys, sometimes you cannot ask the patient to raise from the bed, right? Some patients are bed bound, no? So then you have to do this method, right? So it's good to get used to it, right? Tap the Achilles tendon, look for the jerk, okay? That's about it, okay? Right? So that's about it for the physical examination, guys. Next, we'll do some special investigations, and the management will take a 15-minute break and come back, okay? Right? Right. Guys, are you back? Who here has catcharidophobia? Who is afraid of cockroaches? Anyone here afraid of cockroaches? No? No? Really?
When they start flying, then yes.
Yes, that is the problem. That is the exact issue I have. Right now, just before I turned the camera on, there was a attack, so I had to use some bug spray. Right? Yeah, flying is the issue. If they're not flying, no problem. Right? Right. Good to know I'm not alone. Right. Okay. Right, guys, let's get to the investigations and the management. Nothing much to discuss for these guys because a lot of it involves with the underlying cause, right? So we won't go for in-depth explanations. Second. Right. Right, you can see the screen, all good? Right? Right. Investigations, guys, right? Special tests. Now we've done with the history and the physical, what questions to ask, what to look for, what red flags to look for, yellow flags. We've talked about all of that, right? After all of that, maybe we can get a hint of what is wrong, right? After that, we move on to the investigations to try and further narrow down on the cause, right? To find the exact things. These things, now look at this. First thing is X-ray, guys. Whatever happens when there is a lower back pain, when there is a back pain in general, right? Apart from the red flag kind of pains, right? For example, interscapular pain and all of that. Apart from those, when there is generalized back pain, that is not a red flag sign. Usually we can tell them, okay, get an X-ray, right? Now, all of these three things we have talked about. Ankylosing spondylitis. In an X-ray, what are you going to look for? Ankylosing spondylitis. Tell me now, you all know. Huh? Just recall these. What are we looking for? Ankylosing spondylitis.
Bamboo stick.
Syndesmophytes.
Okay. Syndesmophyte formation, bamboo spine, right? Bamboo spine, syndesmophyte. What is the earliest sign? You all forgot that one? Okay,
Sacral.
Yes, sacroiliitis. How do you see it? How do you see it? How do you describe what you see rather on the X-ray? Sacroiliitis. Blurring out of the sacroiliac joint. Do you remember? Blurring out. That's the first thing. Blurring out of sacroiliac joint, right? Apart from that, yes, you are correct. Syndesmophyte formations, right? And we can have the bamboo spine, right? This is also due to the syndesmophytes, right? Bamboo spine, right? Bamboo spine. TB, an X-ray in a TB patient. What are we looking for? Tell me some things that we talked about yesterday.
Cold abscess.
Sequestration.
Okay, the cold abscess, basically this is from the sequestration, cold abscess, right? Cold abscess. Apart from that, guys, anything else? Any particular special deformity in the TB spine? Gibbous deformity. Yes, gibbous deformity. How does it come? Wedge fracture, right? Wedge defect, right? We call it the wedge defect, right? Giving rise to the gibbous deformity. Don't forget those, huh? Those are important, right? Apart from these guys, you can have other features like disc space narrowing. All of these can be there, okay? But these two don't forget, right? Right. Then osteoarthritis or lumbar spondylosis. What can we see here? What can we see? Now you all already, you all studied this with me. Tell me, what are we looking for? What are we looking for?
Osteophytes, subchondral sclerosis.
Right, osteophytes.
Subchondral
What
cells.
about the disc space? Disc space, what is happening?
Narrowing.
Narrowing, disc space narrowing. Apart from that, sometimes what can be there in spondylosis? In the X-ray, what can you see?
Articular
Fracture.
Yes, fracture where?
Fractures.
At the pars
Passing.
intraarticularis, right? Fracture at the pars intra. So you all can write those down. Even after the class, you all can write them down. Okay. MRI, guys. I want you all to know these things. When do we ask the patient to get an MRI? Is first this, right? Suspected tumors. Write this down. Huh? Suspected tumors or malignancies, right? These are based on our red flag signs. Some of our red flag signs, right? Like severe nocturnal pain, unremitting pain, right? Weight loss, unexplained weight loss, things like this, right? Then again, if we suspected cord compression or nerve root compression. So, right, any manifestation of something like sciatica, any nervous from your neurologic exam, if you notice some sort of defect in a certain especially L4, L5, S1 level, right, you can further to confirm, you can ask them to do an MRI. The other one is, guys, any suspicion of lumbar disc prolapse, right? Lumbar disc prolapse. This is the prolapse. PIBD, prolapse lumbar, PLIBD. Prolapse lumbar intervertebral disc. Right? This is when we ask them to do the MRI. Okay? Right. Full blood count. Why are we doing this? Look at this, guys. WBC counts. One thing, it can be elevated in things like what? Primarily, what should you first come to your mind? Sorry?
Infection.
What is the infection specifically? What do we give the name? What is the name for the vertebra or any bone rather?
Osteomyelitis.
Osteomyelitis, right? Osteomyelitis, right? Okay. Then sometimes, guys, what can we have? Okay, don't write it under this. We'll write somewhere here. RBC count, I haven't included here, guys. You all can put it as the next thing. RBC count, right? Especially we are talking about anemia. Anemia. Where can we see anemia and sometimes pancytopenia as well? Where?
Multiple myeloma.
Multiple myeloma. Think multiple myeloma. Think multiple myeloma. Okay? Think multiple myeloma. ESR, guys. ESR, if it is elevated, erythrocyte sedimentation rate, right? First thing, it can be any infection, no? It can be an osteomyelitis also. Sometimes it can be osteomyelitis, it can be TB, right? It can be ankylosing spondylitis, you might have learned, right? ESR is shown to be elevated. Apart from that, multiple myeloma also can be there. Why ESR is higher in multiple myeloma? Why ESR is higher in multiple myeloma?
Since there is an increase in number of cells, the sedimentation will also increase.
Yeah, what did we say? Not number of cells, the antibody is high. The antibody concentration in the serum is very high. What did we say? Hyperviscosity. Do you all remember? So because of that, right? Then guys, if the ESR is normal, what can it be? Now ESR is what? A marker of inflammation. If ESR is a marker of inflammation. So if ESR is normal, just make sure you suspect referred pains, right? Because there can be a lot of referred pains or sometimes isolated mechanical types of pains, right? Where there is no inflammation, right? So you can suspect other cancers, peptic ulcer diseases, right? You all know how to differentiate those things now, right? Then CRP, C-reactive protein, it's also another inflammatory marker. If it is elevated, guys, think osteomyelitis, you can think TB, all of these things. Osteomyelitis specifically, right? ESR and CRP, guys, specifically if both are elevated, think osteomyelitis first, right? Look at the WBC count also, think osteomyelitis first, right? Okay. Then apart from this, now tell me this, blood smear. If we do a blood smear in a multiple myeloma patient, what will you see? Think of the mechanisms and tell me. Even here, I have lightly said something about it. Blood smear. If you take the patient's blood, look at it under the microscope, multiple myeloma. What will you see? Think about the hyperviscosity of the blood, of the serum. What will you see? Nothing comes to mind. These gamma globulins, guys, these antibodies, right? You know, they have this function of clumping together, sticking together, right? Anything comes to your mind? No, nothing.
Agglutines.
Sorry.
Agglutination.
Yeah, okay. How do we see that in the smear? How can you define? Have you all heard this word? What is this? Rouleau formation. Rouleau formations can be seen. Basically, guys, you will see like long, their RBCs are clumped together like this, right? Long lines you can see like this, right? You will see the RBCs like that. Okay, Rouleau formations, right? In their blood smear, multiple myeloma. Don't worry, multiple myeloma is a hematological topic. We will discuss that A to Z when we come to hematology. Yeah. Okay. We discussed only what is necessary for our back pain, right? There is actually multiple myeloma is a big topic. Okay, apart from that, guys, we can do a liver function test for certain things. Look at this. What I want you all to know, liver function test, we are usually testing these AST, ALP, ALT, all of these things. No, just to note, guys, right, the underlying mechanisms, I know I did not teach you. We will talk about this in multiple myeloma, right? ALP. If you look in a multiple myeloma patient, it's normal ALP, right? Just note that down, right? We will discuss the mechanisms when we come to that chapter, right? If ALP is high, guys, if ALP is shown to be elevated, one thing you all already know, related to GI and related to our chapter, ALP, some sort of a famous one, alkaline phosphatase. Pancreatic carcinoma, write this down. Don't worry. We haven't talked about these mechanisms in depth. Huh? Think about pancreatic carcinoma. Apart from this, guys, even Paget's disease, right? Paget's disease, now you all will learn, right? Paget's disease also can have some elevated ALP and sometimes osteomalacia also. Osteomalacia also can have, right? Elevated ALP, right? Okay. Right. Then look at this, guys. Neoplastic conditions. If you are suspecting any sort of cancer from your physical and your history, right? If you are suspecting any sort of cancer, you can further do investigations to try and localize the primary tumor from where it came to the spine, right? To try and localize that primary tumor. So if you're suspecting bronchial carcinoma, you all know we can do a chest X-ray, right? Multiple myeloma skeletal survey, guys. Skeletal survey means what? In multiple places we are going to take some x-rays, because we also saw multiple myeloma, especially in a lot of the flat bones, right? The skull, right? Scapula, these regions, they can show those lytic lesions, right? They can show the lytic lesion. So you can do some x-rays in some, especially in the areas of flat bones, right? To try and see if there are other lesions, right? Signs of other lytic lesions, right? Then again, for multiple myeloma, you all know we can do gel electrophoresis, right? You can see the M spike. We have discussed this yesterday. Urine, this one I didn't tell you all. Look at this, guys. Now, what do we know about the patient's serum? Serum has a lot of these monoclonal antibodies, right? Monoclonal antibodies, right? The gamma globulins, basically, right? You all know, guys, these antibodies are made up of heavy chains and light chains, right? No need to discuss the structure now. These light chains, guys, they are very light. Okay, they are very light. They're light chains, just like the name implies. So they can be easily lost with urine, right? They can come to your kidney, be filtered, and be lost with urine. In the patient's urine sample, if you see these monoclonal antibody light chains, we give these a special name, guys. We call these Bence-Jones proteins. Bence-Jones proteins, monoclonal light chains in the urine, right, of the antibodies, right? We call these Bence-Jones proteins. So what is this BJP? Bence-Jones proteinuria, right? Bence-Jones proteinuria, right? Now, Nihal, what's up? Huh? Bence-Jones proteinuria, okay? Right? Okay, next one. PSA. What is PSA? What is PSA?
Prostate specific antigen.
Prostate specific antigen, right? We are going to see this for prostate carcinoma, right? There's going to be an elevation of prostate specific antigen, right? Then serum hypercalcemia. Where do we see this? Yesterday we talked about hypercalcemia. When do we see it? Multiple myeloma. And guys, just think about other malignancies as well, right? Other malignancies, because there can be some malignancies, right, causing hypercalcemia, right? Okay, so multiple myeloma is the main one. Apart from that, guys, we can do ultrasound scans, right? These others, I have put it as others. Ultrasound scan, guys, specifically if we are suspecting aortic aneurysms, right? Aortic aneurysms, right? If we are suspecting any renal lesions, right? Can be renal cancers, right? Obviously, there will be other signs like hematuria, pain on urination, all of these things will be there. But if you're suspecting, you can do an ultrasound, right? Renal lesions and even sometimes uterine lesions, right? Gynecological and obstetric, not obstetric, right? Uterine lesions. CTs, guys, CTs again we can order especially for if you are suspecting any pancreatic issues, right? Pancreatic lesions, right? Or aortic lesions, right? Aortic, right? You all know aortic, especially if we are suspecting some dissections, right? Apart from this, what's the other one? MRI, yeah, that one also you all can add here. We have looked at several MRIs throughout our class, right? The MRI also can be done, okay? Okay. Spinal cord lesions, disc lesions, spinal cord tumors, all of these are MRI, okay? Right. Then guys, there are some other tests we don't need to talk about. Now there are things called CT myelograms, right? Not necessary, not necessary, right? Right. Now we will come to the management part. How do we manage a patient coming in with back pain, right? First thing I want you all to know, find and treat the underlying cause, right? That's the main thing, guys. Find and treat the underlying cause, right? Apart from that, some general measures, guys. Now, when a patient comes, let's say you found his underlying cause, until you treat the underlying cause and the underlying cause is gone away, he will still suffer from back pain, right? So because of that, we have some general measures, right? We have some general measures. First thing, regular exercise, guys. Regular exercise. Just remember, don't overwork the back, right? Same like our osteoarthritis. Do you remember osteoarthritis? We said, don't overwork the affected joint, but you shouldn't stop all movements at the same time, right? So it has to be a middle route, right? Not doing, not overworking, nor not doing anything. So do some exercise, some regular exercise. And guys, just note down, especially if the patient is obese, if obese, right? We tell them to try to lose some weight, right? So we can put them on a weight loss diet plan as well, along with some regular exercise, right? Try some weight loss, okay? Especially if they're obese, because when they're obese, right, the spinal cord is under a lot of shear forces, okay? Right. Physiotherapy consultation, yes, guys, especially for these back pains, right? They help a lot, right? Especially these back massage sessions, right? The muscle relaxation sessions, all of these. For chronic non-specific pain, guys, right? We have two, reassurance and this medical management. What is this reassurance? Why this reassurance? Now, chronic non-specific pain, the patient is having a chronic pain, but you cannot point out a direct reason, right? It's non-specific. Why should you reassure the patient? Remember our yellow flags, guys. Remember our yellow flags. We said back pain is related by some mechanisms. We don't know how exactly, to some psychological factors, right? To some psychosocial factors, right? So you have to reassure, you have to focus on the yellow flags, right? And make sure the patient is positive about the back pain and that he is in a mindset where he believes it can be cured. Give me a second. Voice. Right. Right. Then, right, that is about the reassurance. Yellow flags. You focus on the yellow flags. Right. Then medical management. What can we do here, guys? Look at this. Medical management, general. This is general. This is not for any specific cause. We are general management of back pain. Right. First thing is, guys, we can try some basic ones, right? Something like acetaminophen, right? Acetaminophen. Okay. And we can try some NSAIDs, right? NSAIDs, guys, what I want you all to know is we can go with some initial ones, initial cases, right? If the pain is not very serious, we can give them topical NSAIDs, right? To the back. Diclofenac, methyl salicylates, we talked about in osteoarthritis as well. Same stuff, right? Same stuff. Okay. If it is not, guys, usually most of the back pains, right? We prefer to give oral. Why do I say that? Why do I say we prefer to give oral drugs with this back pain? Again, guys, this comes down to our psychosocial issues. These oral drugs, one thing, oral drugs are more potent, especially oral NSAIDs. They are more potent than the topical ones, right? So they can help in reduction of pain more. Apart from that, guys, there is a placebo effect, right? The patient is, I'm taking tablets for my back pain, it should go away, right? Okay, this is how because it's a mind game here as well. This back pain, that's why we said it's not like these other conditions. Okay, when the patient feels he's taking some medicine, okay, right, he has some confidence, right? Okay, so that is, those are the two reasons there, right? Right, then again, y'all know the examples, right? Diclofenac, whatever, right? You can give all of the ibuprofen, right? The coccids, you can give the coccids. Watch out for things like peptic ulcer disease and all of those. Same principles apply, right? Then guys, there is also a place, especially if the patient is a previously diagnosed, either patient with depression, bipolar disorder, things like this. There is a place for antidepressants. Again, why I'm stressing this, because this back pain has a major role with psychological issues, right? This is what we talked about at the start. We don't know the exact mechanisms, but there are psychosocial issues, right? Look at this, guys. Antidepressants. Now think and tell me, what is the problem with giving antidepressants in a back pain patient? Antidepressants are good to some extent, especially if the patient is diagnosed with some history of some mental problems, right? Psychological problems, whatever. What is the problem? Yesterday's class we talked about. Okay, I will tell you some agents that we commonly give. We can give things like carbamazepine, right, for mood stabilization. We can give some tricyclic antidepressants, sometimes phenytoins, right? What's the issue? Yeah, I see you all smiling. You all know.
P450.
Yeah, the cytochrome problem, right? So what can happen? What is the end result? Osteomalacia, right? Osteomalacia. So you have to watch out for osteomalacia. If the patient is already someone with osteomalacia, you have to be very careful, right? Okay, you can give them with the vitamin D, but you have to be careful. Okay, so just make note of that. Okay, right. So it's better to give it with vitamin D3. Better to give with vitamin D3. Then guys, again, this acupuncture, right? Spinal manipulation, right? The thing is, guys, there is a psychological factor here as well, right? More than just the medical aspect of it. There is a medical aspect as well. Can help. Can you all hear the rain? Okay. If you all hear any sounds, just let me know. It's heavy rain here, right? Okay. So those are the general manifestations, right? Right. Then guys, for some specific ones we'll talk about, not all of them. If there is an acute lumbar disc prolapse, right? Lumbar disc prolapse, what do we say? It can pain, right? There can be some severe pain, especially unilateral type, right? The bulging disc we talked about. Here guys, initially we tell the patient to take some bed rest for 2 to 3 days. 2 to 3 days is enough, not more than that, right? Too much bed rest is also not good. Okay, take some bed rest for 2 to 3 days. We can give some analgesics, guys. What we prefer is opioid analgesics. Opioid analgesics, opioid analgesics, guys, the most common one. Just remember this. There are a lot, right? There are a lot. Just remember tramadol, right? Tramadol. That's easy, no? Like Panadol. Tramadol. This is an opioid analgesic, right? Opioid analgesic. Apart from this, guys, some muscle relaxants can be given, right? No need to know the names, but if you all want to know, right, it's you all can get the gold medal. Some commonly used ones, guys. Cyclobenzaprine, right? Then we have methocarbamol. Not needed, guys. If you all want to just remember, cyclobenzaprine and methocarbamol, there are actually 5 or 6, right? Not necessary, right? Methocarbamol is now quite famous, right? If you all have heard, it's up and coming. It's a good drug. It's a good muscle relaxant, right? Right. Then, guys, once the pain is tolerable, so now we use these first 2 steps, right? The bed rest and the analgesics and the muscle relaxants. right? For about 2 to 3 days, sometimes a week max, right? And once the pain is tolerable, we tell the patient, okay, now it's time to move around a little, some mobilization and some physiotherapy, because this lumbar disc prolapse, guys, when it happens acutely, right? Especially a patient who has never experienced it before, they find it very painful, right? They find it very painful, right? So once the pain is a little bit tolerable, right, we tell them, we give them advice on mobilization and physiotherapy. Okay, right. If the pain, write this down, guys. If the pain persists, if it is persisting plus severe, right, put a plus severe there, right? If the pain is persisting greater than 6 weeks and the pain is severe, right, we have to consider surgery for lumbar disc prolapses, right? We have to consider surgery. What are the surgeries we do, guys? Look at this. There are mainly two, right? One is called microdiscectomy, right? The second one is hemilaminectomy or laminectomy. Both are an option. Look at this. I will just show you, just to give you a small idea. Look at this, guys. If I draw this like this, you all know, in the middle is our spinal cord, right? The nerves coming that way, right? Something like this, no? Now, what is happening in this, in lumbar disc prolapse, what is happening, right? There is a bulging out like this. There is a bulging out like that, right? There is a bulging out like that. Okay, right? So what is this microdiscectomy, guys? We cut off, we can do surgically, we can cut off only this bulging out portion. Only this bulging out portion we can cut off, right? This is what we call a microdiscectomy. Microdiscectomy. Only the bulging out portion we cut off, right? In some patients, guys, in some patients, right, this lumbar disc prolapse, right, it is recurring. It comes, right, they do some surgery or they do some management, okay, it goes away. Then again, in another area, in another, maybe the vertebra below that, again another prolapse, right? They have some inherent weakness, right? They have some inherent weaknesses in their cartilaginous structures, or maybe they are smokers, maybe they are chronic heavy smokers, right? So when it is a relapsing case like that, we prefer this hemilaminectomy or the laminectomy. What are we doing here? Look at this, guys. Let me show you all that also. So if this is the same thing, let me write something like this, right? This is how it is now. What can we do here, right? We can do two things. Look at this. Let me draw the prolapsing spine also. Right, something like that. Look at this, guys. I can do two things. I will draw both. 1, 2. Look at this. Hemilaminectomy. What is this hemilaminectomy, guys? We take the affected side. Now in this patient, this side is affected. What we do is we cut off from here, from the lamina, right? We cut off from the lamina and remove this part, right? Now look at this. Now, even though the disc is bulging, our spinal cord has space to move backwards, right? The spinal cord has space to move backwards, right? So this is the hemilaminectomy. Okay. Total laminectomy is what, guys, right? It's the same thing. We do it something like this. Look at this. Let me draw it in a, guys, let me draw this in a better way. Otherwise, you all might get confused here. Give me a second. Look at this. Let's draw it this way. It's easier for you all to understand it. Right, let me draw. Y'all can keep the drawing. It's okay. Y'all can just draw this underneath. It's the same thing, but it's a little bit clearer in this way, right? It's something like this. is what we have this now. Right. Look at this. Look at this, guys. The hemilaminectomy. When I drew the previous one, you all will think that the facet joints are removed. That's why it's not very accurate. Here, what we do is this. Now, let's say this thing is bulging this way, somewhere here. Let's say it's bulging somewhere there, right? Somewhere there, bulging somewhere there, right? Here, what is this hemilaminectomy story? We are going to cut off from here, guys, the lamina portion, the lamina portion. The other facet joints and everything, we keep it there like that. We cut off this portion here, and this one joins like that, right? Now, look at this. Now, even though the prolapse is happening from here, right? Even though the prolapse is happening from there, right? The spinal cord has enough space to come backwards on that side, on the affected side, right? I hope you all understand that. Same thing, full lamina. That was the hemilaminectomy. Full laminectomy, guys, we remove this entire thing. Look at this. The spinous process, we remove it there from the two lamina, from the both lamina. Okay, is what I want you all to. Now look at this. So now here, right, the spinal cord has enough and more space to come backwards, right? Enough and more space. So this is laminectomy and hemilaminectomy. Okay. Okay. Right.
I mean, I'm assuming this means the patient has to take precautions against,
Yes.
like,
Yes.
because the part missing in the back. Yeah.
The part is missing in the back. Just remember the facet joints are intact, because you all know from here there is a facet joint here, right, connecting to the vertebra above and the vertebra below. So even in this one, the facet joints are there. Facet joints are there, but yes, you're correct. There is going to be some. It's going to be a little bit more fragile than usual, right? So yeah, you have to be careful, right? But you weigh the advantages and the disadvantages. The patient's pain, right, is going to go away. It's going to go away, right? So they are going to feel a lot more better, right? So if there are someone like an athlete, guys, if there's someone like an elite athlete, right, either they will have to stop the sport, or we don't usually do these laminectomies in elite athletes. Okay, we usually go for other methods, right? Okay, right. Then, guys, one more place where you consider surgery. Where? A red flag. Where? Cauda equina syndrome, a neurosurgical emergency. Write that down, right? Cauda equina syndrome. It's a neurosurgical emergency. Immediately you have to consult the neurosurgeons and fix the issue. Okay, fix the issue, right? Cauda equina syndrome, right? Then, guys, infections, right? Again, you have to find out the infection. If it is TB, you have to treat the TB. If it is osteomyelitis, you have to make sure you don't allow the patient to go to septic shock, right? Depending on the specific type, you will have to do cultures and give the particular what do you call osteomyelitis? What's the most common organism? What's the most common organism?
Sorry.
SORIAS, right? So apart from that, for the pain, guys, you can give NSAIDs and again tramadol or something, some opioid analgesics. Okay. Arthritic pain, again, now these you all have discussed in depth over and over, how to treat, if it's osteoarthritis, if it is rheumatoid, whatever, right? About the other types of seronegative arthritis, all of those treatments, right? You have to remember TNF can be used, right? I hope you all remember. Okay, right? I see some. Just go back to those notes. For the arthritic pain, once you diagnose the specific type of arthritis, treat that, because that is the trigger factor. Those are the trigger factors, right? For arthritis, guys, further what we, even for osteoarthritis, we said, right, intra-articular corticosteroids can be used, right? But we prefer if it is a monoarthritis, if only one place is affected, that's okay, right? Okay. Otherwise, maybe not, right? Okay. If it's multiple joints, we don't like to give corticosteroids, inject corticosteroids everywhere, right? So for polyarthritis, we usually again go with NSAIDs. Okay. Then that's about it, guys. Other things, managements, right? We don't need to talk about here, but just treat the underlying cause. It can be SLE, right? You have to treat the underlying SLE, right? Things like that. Then the back pain will resolve. Okay. So that's it for back pain. So I know some juniors found this session, I mean, not today's only, even yesterday's session, a little bit difficult, because this one, as I said at the start, guys, it's a lot of conditions, right? It's a lot of different conditions, right? Ultimately resulting in back pain. So it's not like one pathophysiology that we discussed nicely, mechanisms and all of that, right? But this is the only chapter like that in this module that we need to discuss in this way. Others are individual chapters, right, by themselves, right? The back pain is your viva. That's why we have to discuss it like this, right? Okay, let me see some faces. Are you all happy? Are you all sad? How are you all feeling? Guys, turn your cameras on. At least at the end, let me see your faces. Tarinda, all good? Understood everything? Yeah. Who else is here? Sarah, understood everything? All good? Sarah, which year are you in? Which year of?
Third year.
Third year. Okay. All right. Okay. Okay, so the other students' cameras are not turned on. Okay, let me come back here. Right. Now, Nihal, all good? Right? Okay. Tiara, all good? Panchali, all good? Right? Okay. Right, guys. So that's about it from me. The next lecture, Shan will inform you all, right? He will put a reminder. My next lecture for you all is SLE, right? I will meet you all again on 16th, right? So that's about it for this chapter. If you all have any questions, drop me a message. Okay, that's about it. See you guys at the next one. Okay.
Thank you.
Yeah,
Thank
no
you so
problem.
much.
You're welcome. You're welcome.
Right.